My name is Liwayway Hussein. I live in Dar es Salaam, Tanzania, East Africa. Today we're going to talk about diabetes and its complications, focusing on macrovascular complications. Diabetes, we have type 1, type 2, and other types which I'm not going to go into today. The complications are divided into two. We have the microvascular complications, which include neuropathy, retinopathy, and nephropathy. And then we have the macrovascular complications, which include the coronary artery diseases, peripheral artery diseases, and stroke. This can also be termed as cardiovascular diseases. Cardiovascular diseases are on the rise, not only in developed countries, but also in developing countries. In developing countries, we are soon going to face an epidemic if we're not facing it now. Current literature states that cardiovascular diseases, even in East Africa, are on the rise. And as family physicians, we need to put this in mind so that we can develop strategies to prevent cardiovascular diseases. Cardiovascular diseases is the major cause of morbidity and mortality for individuals with diabetes, and the largest contributor to the direct and indirect cause of diabetes. The common conditions which coexist with type 2 diabetes are hypertension and dyslipidemia. Diabetes on itself confers an independent risk. Numerous studies have shown the efficacy of controlling individual cardiovascular risk factors in preventing or slowing cardiovascular diseases in people with diabetes. What I would like to start with is to talk about the pathological mechanism in macrovascular diseases. The central pathological mechanism in macrovascular disease is the process of atherosclerosis, which leads to narrowing of arterial walls throughout the body. Atherosclerosis is thought to result from chronic inflammation and injury to the arterial wall in the peripheral or coronary vascular system. In response to endothelial injury and inflammation, oxidized lipids from LDL particles accumulate in the endothelial walls of arteries. Angiotensin II may promote the oxidation of such particles. Monocytes then infiltrate the arterial wall and differentiate into macrophages, which accumulate oxidized lipids to form what is called foam cells. Once formed foam cells stimulate macrophage proliferation and attraction of T lymphocytes. T lymphocytes in turn induce smooth muscle proliferation in the arterial walls and collagen accumulation. The net result of the process is the formation of a lipid-rich atherosclerotic lesion with a fibrous cap. Rupture of this lesion leads to acute vascular infarction. In addition to atheroma formation, there is strong evidence of increased platelet adhesions and hypercoagulability in type 2 diabetes. Impaired nitric oxide generation and increased free radical formation in platelets, as well as altered calcium regulation may promote platelet aggregation. Elevated levels of plasminogen activator inhibitor type 1 may also impair fibrinolysis in patients with diabetes. So, the combination of increased coagulability and impaired fibrinolysis likely further increases the risk of vascular occlusion and cardiovascular events in type 2 diabetes.